Preventable disease. That you'll be able to implement specific vaccine recommendations for children with CKD and end-stage kidney disease into practice. And that at the very end, I will talk a little bit about some guiding principles for immunizations of children with chronic medical conditions, including chronic kidney disease. Okay, so moving on to our first objective. Infection is among the leading causes of morbidity and mortality in patients with underlying chronic kidney disease, including those with kidney failure and those who are undergoing dialysis or transplantation. CKD results in a state of immunosuppression that is likely multifactorial due to a combination of innate and adaptive immune dysfunction, chronic inflammation, endothelial cell dysfunction, and uremia. The incidence of infection and infection-related hospitalizations has been shown to increase as kidney function declines, although this really is not very well characterized by the individual stage of kidney dysfunction. So when I talk about CKD during this lecture, I'm really kind of referring to all stages of CKD. High rates of infection among patients with end-stage renal disease and earlier stages of CKD are also a consequence of advancing age, which is more commonly seen in adults, obviously, as adults get older, comorbid conditions like diabetes, and then high rates of hospital admission for treatment of CKD. And then the risk for infection in kidney transplant patients is compounded by the need for immunosuppression to prevent rejection. So immunization is an important component of preventative care for patients with CKD, but unfortunately, those with advanced stages of kidney disease or those patients who might be on immunosuppression, they generally have poorer response to vaccines. And so they may have lower rates of seroconversion, lower antibody titers, and less sustained response compared to their healthy controls. Now, some studies have demonstrated that the response to vaccines will decrease as kidney disease stages advance. So as your kidney disease gets worse, your ability to respond to vaccines gets lower. And so it suggests that earlier immunization of these patients is really important and likely beneficial. Of course, it would be nice to have really great data on this. And unfortunately, I don't know that there's a whole lot of great data on immunizations in general, but if you looked up a specific vaccine, you might find some information on that specific vaccine itself. Vaccination rates, we have found, at least in adult kidney disease patients, are not great. It feels that adults don't get the vaccines that are needed. And so there has been some undertaking in the United States to try to really get our children with kidney disease vaccinated, since there's a nice system in place for children to get immunizations. So moving on to our second learning objective, and that's really implementing specific vaccine recommendations for these children. So as you can see here, the number of vaccines in our armamentarium has grown exponentially over time, and studies have shown that the clinically preventable burden of disease, so the proportion of diseases and infections that are prevented by immunizations, is higher for the routine childhood immunization schedule in the United States than for virtually any other routine public health intervention. And so you can see that over the years, and even really in my lifetime and in your lifetime, the number of vaccines that we have to prevent infection has truly exponentially increased. And so this is the recommended child and adolescent immunization schedule for children in the United States. You can see the list of the vaccines there on the left-hand side, and then you can see the age on the top of the table, and the yellow boxes say kind of when to give a dose of each of those vaccines. If a child were to get all of the recommended immunizations in the United States on time and at the correct ages and intervals, then this will help protect children against 19 different pathogens, which is truly impressive. I think when I was a child, I got vaccinated against 6 things total. And so the number of vaccines that we give now and the number of infections we can prevent is truly incredible. Now, as a general rule, in children with CKD, it is recommended that they receive all routine vaccines, and that these should be given according to age and the correct interval, unless for some reason the vaccine is specifically contraindicated in that patient. And so, for example, this would include that all of our patients with CKD should be vaccinated against hepatitis A, diphtheria, tetanus, and pertussis, Haemophilus influenzae type B, polio. We vaccinate against human papillomavirus, and then we vaccinate routinely against 4 different serogroups of meningococcus, A, C, W, and Y. And we also have a meningococcal B vaccine that we can use. It is additionally recommended that patients with CKD undergo immunization for hepatitis B, for pneumococcus, for flu, and for COVID-19. And these are particularly important in our patients with CKD or who may be immunocompromised after undergoing a kidney transplant. And I'm going to walk through each of these here in a few minutes in more detail. Live viral vaccines in most cases can be given to children with chronic kidney disease unless they are also on immunosuppressive medications. And so if you have a patient who has CKD and is on immunosuppression, then live viral vaccines may be contraindicated in that patient. Those would include the varicella vaccine, the measles, mumps, and rubella vaccine, and then the live attenuated influenza vaccine. And so we do not routinely give those to our patients who are on immunosuppression. Now, again, for our regular CKD patients who are not on any sort of immune suppression, most of those vaccines would be okay. Now, in addition to the routine childhood vaccination schedule, the Advisory Committee on Immunization Practices in the United States, which is a committee that is part of the Centers for Disease Control, also publishes each year this table, which breaks down which vaccines should and should not be given to patients with certain underlying diseases. And as you can see highlighted by the red box, there is a column that highlights what vaccines patients who have kidney failure, end-stage renal disease, or are on hemodialysis. And there are no specific vaccines that are contraindicated in that population. That is different than the separate column that is highlighted on this slide that does show that if you are immunocompromised or on any type of immune suppression, there will be some vaccines that are contraindicated. And this includes the MMR, which is the measles, mumps, rubella, the varicella, the live attenuated influenza vaccine. And then that also includes our dengue vaccine, which we do not give routinely to children in the United States, but is available here. So at this point, I'm going to go into talking a little bit more specifically about the diseases and the vaccines that we really stress the importance of in our CKD patients. So I want to talk about hepatitis B first. So first, a little bit about the clinical infection, which I'm sure everybody knows about, but hepatitis B, the infection, can cause both acute and chronic disease. The acute illness can be asymptomatic or symptomatic. And if a patient has symptoms of acute illness, they may present with anorexia, nausea, or malaise, clinical hepatitis, fulminant hepatitis, and 5 to 10% will then go on to develop chronic infection. And this rate is actually higher if you are younger in age when you acquire hepatitis B. The chronic disease is characterized by liver dysfunction that gets worse over years. Ultimately, these patients may go on to develop cirrhosis, and some will even develop hepatocellular carcinoma. Hepatitis B virus is transmitted by blood or body fluids, which puts patients on dialysis at higher risk for acquiring this infection. The incubation period is prolonged, lasting from anywhere from 45 to 160 days from exposure to when the patient may develop clinical symptoms. And then hepatitis B is one of those viruses that can live for a long time on surfaces for up to 7 days. Now, this graph demonstrates the number of new hepatitis B virus infections in the United States since 1980. And in the US, we started vaccinating patients routinely in the 80s, as you can see where the arrow is. And since that time, the number of new cases in the US has gone down significantly, proving that our vaccine and the universal vaccination strategies that we have employed in the US have been working. Now, I'm going to pause here and give a little bit of information about the different types of testing that might be used when looking for hepatitis B infection or for response to immunization. I think these can be a little bit confusing, and so I just wanted to make sure that I went through the different factors that can be tested and what those abbreviations are and how those are used. Are there any questions? Sorry. So HBs antigen, or hepatitis B surface antigen, abbreviated there, is the test that we use to detect acute or chronically infected patients with hepatitis B. It is also the same antigen that is used in hepatitis B vaccines. So if you were to check this test right after somebody got the vaccine, this may be positive for up to 3 weeks after receiving the vaccine. However, if the patient hasn't received the vaccine recently, a positive test result with this test may indicate a patient who is acutely or chronically infected. Anti-HBs, or is the abbreviation for antibody to hepatitis B surface antigen, and this lab test is performed to identify people who have resolved infections with hepatitis B virus, and it also helps determine immunity after immunization. So if a patient is tested for this alone after receiving the hepatitis B vaccine series, then we would expect it to be positive to demonstrate protective immunity. And I'll talk a little bit about that, more about that in a moment. And then finally, the last test that I'm going to talk about, there are a lot more hepatitis B tests, but the last one I'm going to talk about right now is the anti-HBC, which is antibody to hepatitis B core antigen. And this test is performed to identify people who have acute, resolved, or chronic hepatitis B virus infection, and is only present in patients who actually have had the infection. It will never be positive in a patient who does not have hepatitis B infection, but who may have been vaccinated. And so this test should be negative in patients who have never been infected. So just quickly to kind of illustrate how these labs are used in testing, if you test a patient who has never been vaccinated for hepatitis B and has never been infected with hepatitis B, then all three of these test parameters will be negative. Occasionally, you may send these tests on a patient who will still be all negative for all three, but who is truly fully vaccinated against hepatitis B and has never been infected. In a patient like this, these test results likely demonstrate that the patient has waning immunity to their hepatitis B vaccine series. And so you're not detecting that antibody right now. And so it may look like they're not protected by the vaccine. We know this can happen, but it does not necessarily mean the patient doesn't have immunity. It's just that it's difficult to measure in a patient who may have gotten the vaccine series a long time ago. Usually, if a patient has been fully vaccinated and does not have a history of hepatitis B disease, they will test positive for the antibody to hepatitis B surface antigen. That's the anti-HBs here. And they will test negative to the antigen itself and to the antibody to hepatitis B core antigen. And so the third row in this profile on this table, you would expect to see a patient who has been vaccinated, has durable lasting immunity that you can measure, and has never been infected with the virus. And then finally, patients who have a history of resolved or chronic hepatitis B virus infection will test positive for the antibody to hepatitis B core antigen, but they may test positive or negative to the antigen itself, depending on whether they have resolved infection or chronic infection. So you're probably wondering why this is important when we're supposed to be talking about immunizations. And I'm going to get to that in just a second. So 3 doses of hepatitis B vaccine should be given to all children in the United States. And this includes children who have chronic kidney disease or who are about to undergo kidney transplantation. We give the first dose of hepatitis B vaccine as early as birth, like right after they're born. But if the patient does not get their first dose at birth, they can get it at any age, and the rest of the series of doses, so you still get 3 doses, but the rest of the series will be given at specific intervals after that first dose. So the second dose can be given as early as 4 weeks after the first dose, and the third dose can be given at least 8 weeks after dose 2, but also must be at least 16 weeks after dose 3. So as long as the intervals are met, it does not matter at what age the hepatitis B series is started. The 2 main hepatitis B vaccines that we use in the United States, and there are a couple of other vaccine products as well, but these are the 2 main ones, are very efficacious and immunogenic, regardless at what age the series is started. They provide 95 to 100% seroprotection in infants, children, and adolescents. And they are 89 to 95% they provide 89 to 95% of adults with seroprotection as well. As I mentioned earlier, however, antibody levels may wane, and so that anti-Hep B surface antigen antibody level may decrease over time, particularly if you test that level in an adult patient who may have been immunized as an infant. The thought is, though, that even though antibody levels are wane and may be difficult to measure, the patient still probably has some immune memory and protection persists. And so studies have shown that there are serologic indicators of protection and cell-mediated immunity as far out as 30 years after vaccination. So as I said, the hepatitis B vaccine is universally recommended for all children under the age of 19 in the United States. But if a patient who presents with any stage chronic kidney disease, or if a patient has end-stage kidney disease on hemodialysis, or is a patient undergoing evaluation for kidney transplant, and they have not been vaccinated, it is recommended that they undergo vaccination at the time of evaluation for these disease states. And those unvaccinated patients should receive the 3-dose series as discussed in the previous slide. Now, going back to antibody levels, as well as the Hep B surface antigen testing, our guidelines recommend that in most cases of chronic kidney disease, you do not need to check the anti-HBs antibody level before vaccination, and you don't have to test these children to see if they have hepatitis B. That is different than the child who is about to start or is currently on hemodialysis, or the child who is undergoing kidney transplantation. So regardless of whether they have received hepatitis B vaccination, the patients who are about to start or who are on hemodialysis and the children who are undergoing evaluation for kidney transplantation should be tested for hepatitis B infection with the 3 lab tests that we talked about: the anti-HBs antibody, the anti-HBC antibody test, and a hepatitis B surface antigen, or HBsAg. And then finally, if the patients had not been vaccinated previously and they undergo immunization now, and this again includes the patients who are about to start hemodialysis or who are undergoing kidney transplant evaluation, then they should also have antibody to hepatitis B surface antigen, or anti-HBs, checked after they undergo the full series of vaccination to ensure that they have mounted an appropriate antibody response after they got the vaccines. Additionally, children who remain on hemodialysis are recommended to have this testing done every year while they remain on hemodialysis. So in these patients who undergo vaccination, the 3-dose series, and then need to have the hepatitis B surface, or the antibody to hepatitis B surface antigen checked, it is recommended to obtain that test 1 to 2 months after the final dose in the vaccine series. You're looking to see if the patient mounts an antibody response of 10 or greater. If they do, if the level is 10 or greater, then that patient is considered seroprotected and you don't have to do anything else with that patient. If the level is less than 10 immediately after completing the series, then that patient is recommended to undergo a full 3-dose series again, as if they had never been vaccinated. At the completion of the second series, it is recommended to check the anti-HBs antibody level again. If it is 10 or greater, then they are considered seroprotected. If it remains less than 10, then this patient is called a non-responder. And so those patients are considered at risk of acquiring hepatitis B virus if they are exposed to someone or to body fluids that are positive for hepatitis B. And so we just recommend that those patients be educated about that risk. Now, for patients who are undergoing hemodialysis, it is recommended in the United States to get hepatitis B serology every year to ensure that their seroprotection has not waned below 10. If the antibody to hepatitis B surface antigen level is greater than 10, then nothing more needs to be done. But if it is less than 10 on these annual checks, then it is recommended that the patient on dialysis should receive a booster dose of the vaccine. They just get 1 dose in this case if they've already done their full series before. And they don't need to be retested after the booster dose. But if they remain on dialysis, they should be tested every year to make sure they continue to have quantitated antibody levels to hepatitis B, because they continue to be at risk for being exposed to hepatitis B during dialysis. Okay, that's the first part about hepatitis B vaccine. I'm going to move on now to talk specifically about Streptococcus pneumoniae. Also, I will be referring to this as just pneumococcus because it's a little bit shorter to say. So as you know, Streptococcus pneumoniae, or pneumococcal infections, pneumococcus, is a lancet-shaped, gram-positive, catalase-negative diplococci. It's a bacteria and there are more than 90 different serotypes that are based on unique polysaccharide capsules of each organism. Pneumococcal infections are a leading cause of serious illness among children and adults worldwide, leading to invasive pneumococcal disease, or IPD, such as meningitis, septicemia, and pneumonia, as well as milder but more common illnesses such as sinusitis and otitis media. It is the leading cause of mortality from pneumonia worldwide. The bacteria regularly colonizes the human nasopharynx and can be transmitted person to person, usually through respiratory droplets. Infants and young children are the main reservoir for this bacteria, and nasopharyngeal carriage rates in children range from 21% in industrialized countries to more than 90% in resource-limited countries. Before the widespread introduction of pneumococcal conjugate vaccines into national immunization programs, which started back in the early 2000s, the reported average annual incidence of invasive pneumococcal disease in children under the age of 2 was reported to being 44.4 per 100,000 per year in Europe, and 167 per 100,000 per year in the United States. The risk of pneumococcal disease decreases after early childhood, as you can see here by the rate shown in the darker blue, suggesting acquisition of natural immunity as the patients get older. And this likely includes the development of antibodies to capsular polysaccharide, protein antigens, and then the development of cell-mediated immune responses. Now, this graph shows the percentage of deaths by pathogen in children under the age of 5 worldwide before the introduction of global pneumococcal conjugate vaccine immunization programs. This graph was made using data from the World Health Organization Global Burden of Disease data from 2002. And nearly 1/2 of infection-related deaths were due to 5 organisms, with pneumococcus being second really only to malaria. And even after the introduction of pneumococcal conjugate vaccines, pneumococcal infections still accounted for more deaths than all other causes combined in the year 2016. It is thought that the WHO estimates that pneumococcus kills close to 500,000 children under age 5 worldwide every year, which is about 15% of deaths in children of that age. So before I move further into immunization practice, I wanted to just go over the abbreviations that will be used in the next several slides. Like I said, invasive pneumococcal disease is abbreviated IPD, and then the pneumococcal conjugate vaccines are abbreviated by the letters PCV, and the number after that represents the number of serotypes in that vaccine. And over the last 23 years, we have had 5 different pneumococcal conjugate vaccines developed that have been used at least in the US and in other countries worldwide. The pneumococcal polysaccharide vaccine I have abbreviated as PPSV23, and it contains 23 polysaccharides from 23 different serotypes. So here you can see a timeline of when pneumococcal conjugate vaccines were introduced. In February 2000, the PCV7 vaccine was licensed in the United States for use among infants and young children. And it was found to be very safe and highly efficacious against pneumonia and somewhat effective in reducing ear infections and related office visits. They also recommended that this vaccine be used in children between the ages of 2 and 23 months routinely, and also for children between the ages of 24 months and 59 months who were considered at increased risk for pneumococcal disease, which included children with chronic kidney disease. Other countries may have used PCV10 starting around 2009. Here in the US, we moved on to PCV13 in 2010. The Pneumovax, or the PPSV23, has been authorized in the United States since the mid-1980s for children with high-risk conditions who are over the age of 2. In 2022 and in 2023, there have been 2 additional pneumococcal conjugate vaccines that have been authorized in the United States. PCV15, which protects against 15 different serotypes, which was authorized at the end of last year, and PCV20, which protects against 20 different serotypes, which was just authorized, and we do not yet have the specific recommendations for the use of that vaccine yet. PPSV23 continues to be recommended for children at high risk for disease who are over the age of 2. In case you're interested, these are the serotypes in each of the vaccines. Each of these contain the serotypes of the previous numbered vaccine, plus the additional serotypes that you can see in the right-hand column. Now, there are more than 90 known serotypes of pneumococcus, and the distribution of serotypes that cause disease does vary over time and by age, disease syndrome, and disease severity, as well as geographical region and the presence of antimicrobial resistance genes. And before the introduction of the pneumococcal conjugate vaccines in the different World Health Organization regions, 6 to 11 serotypes accounted for more than 70% of all invasive pneumococcal disease, with number 14 being the most commonly encountered serotype worldwide. And you can see in this graph the different serotypes and the proportion of invasive pneumococcal disease that the serotypes cause. And then you can see that most of these serotypes are now included in the different pneumococcal conjugate vaccines, which I have kind of separated by color. Now, we know that the pneumococcal vaccines work in preventing invasive pneumococcal disease. As you can see, we introduced pneumococcal, or the PCV7 vaccine in 2000, and you can see a steep decline in the number of cases of invasive pneumococcal disease among children who are under the age of 5 in the United States in the next 10 years. We then introduced pneumococcal 13, or the PCV13 vaccine in 2010, which further decreased the number of cases of invasive pneumococcal disease over the next 10 years, as you can see here. Now, the risk for invasive pneumococcal disease is highest among patients who have underlying conditions, including immunodeficiency, HIV infection, absent or deficient splenic function, like in sickle cell disease. But children with chronic renal failure are also at significant increased risk, as you can see by this graph. So if you look at the rate of invasive pneumococcal infection, and this is from 2007 in the United States, so before the PCV13 vaccine was licensed, The black bars represent children, or the number of cases in children between the ages of 5 and 17 years. And the blue bars represent the number of cases, or the rate per 100,000 in children under the age of 5. And you can see that chronic renal failure does seem to put these patients at significant increased risk compared to no at-risk condition, which is the bottom line in the graph. Now, the risk for invasive pneumococcal disease is also, or the rate of pneumonia due to invasive pneumococcal infection is also very high in these patients. And you can see that the rate per 100,000 patients with chronic renal failure is pretty significant and mirrors those patients who have underlying immune deficiencies. And so our patients with chronic renal failure are at significant risk from infection due to pneumococcus. And so therefore, here in the US, again, it is recommended that all children undergo immunization with pneumococcal conjugate vaccine, but it is especially important for our patients with high-risk conditions. So this is the recommended schedule for pneumococcal conjugate vaccine in the US. We usually do 3 primary doses in the first 12 months of life. We start the series at age 2 months. We give 3 doses, usually before the first birthday, and then we give a booster dose sometime between 12 to 15 months of age. And so that is really the recommendation for all children. However, if they don't start their vaccine series between 2 to 6 months of age, we have a slightly different schedule, as you can see here, based on the age at which the child starts the vaccine series. So if they start the series between 7 and 11 months, they get 2 doses in the primary series, followed by a booster dose at 12 to 15 months. And if they don't start their series until they are over a year of age, but still under the age of 2, then they just get 2 doses and no specific booster dose is indicated. Now, in children who are between the ages of 24 and 71 months, if they do have chronic kidney disease, it is recommended that they get 2 doses, usually separated by 8 weeks, and they do not necessarily need a 3rd dose or a booster dose. And then finally, a child with CKD who is between the ages of 6 to 18 years, if they have never received a pneumococcal conjugate vaccine, we do recommend that these patients get at least 1 dose of pneumococcal conjugate vaccine, because they do continue to be at increased risk for invasive pneumococcal disease. Now, in the US, we also recommend the Pneumovax, which is the PPSV23. This is recommended for children with CKD. It should be given 8 weeks after, or the first dose of this vaccine should be given 8 weeks after the last dose of the pneumococcal conjugate vaccine, as long as the child is 2 years of age or older. So the idea is that they complete their full series of their pneumococcal conjugate vaccine, they turn 2, and then as long as it has been 8 weeks after their last pneumococcal conjugate vaccine dose, we give a dose of the PPSV23. They are then complete for pneumococcal vaccination for the next 5 years, which 5 years later, we will give a second dose of the PPSV23 to help provide longer lasting protection as they get older. And I think that is all I have about pneumococcal vaccine. So the last 2 specific vaccines I'm just going to mention and talk about is influenza and COVID-19. We all know that influenza is an orthomyxovirus. There are 3 types, A, B, and C. The annual epidemics are caused by influenza virus types A and B, and influenza A viruses are further subclassified based on their surface antigens, which include hemagglutinin, neuraminidase, and we will know these different subtypes of influenza A viruses by their names like H1N1 and H3N2. And in most influenza vaccines, both influenza A and B virus antigens are included in the seasonal influenza vaccines. So when you look at children who die from a vaccine preventable disease in the United States, you can see that the number of deaths due to influenza far outnumber the number of pediatric deaths due to the other listed infections that are vaccine preventable that you can see here. There are more deaths, at least in this time period, due to flu than there were due to meninge here in the United States. So we consider flu a pretty serious infection that has a high, it is one that we can prevent potential morbidity and mortality with our vaccine. Oops, sorry, let me go back. And then if you look at the specific, when you break down the mortality rate by age, you can see that unfortunately our youngest patients, those under the age of 6 months, have the highest mortality due to influenza when compared to other ages. So it's been hard to really quantify the burden of influenza disease in the last few years because the COVID-19 pandemic has really altered the number of cases of influenza we have seen, I think worldwide and including in the United States. These are the most recent numbers that I have from the 2022-2023 influenza season. And as you can see, the numbers are quite daunting and high. These numbers do include both adults and pediatric patients. We do not have the breakdown of pediatric morbidity and mortality from the previous season yet. I expect that the CDC will release that probably within the next 6 to 10 months. But you can see that there is estimated to be between 19,000 and 58,000 deaths due to flu in the United States last season. So due to the high burden of disease, which is associated with morbidity and hospitalizations, it is recommended that all children who are 6 months of age or older be vaccinated against influenza annually. And so for our CKD patients, we do recommend that this is with the inactivated influenza vaccine. And so we do recommend this for all of our CKD patients. We recommend that it be given annually. If the patient is going to get a flu vaccine this year, and they are between the ages of 6 months and 8 years of age, and they have never had a flu vaccine before, then they do need 2 doses in their first season of getting flu vaccine. And those 2 doses are usually given 4 weeks apart. Otherwise, beyond that, once they've kind of undergone that 2-dose regimen, then each additional year after that, they just need 1 dose. And then for children who are 9 years of age and older, also only need 1 dose in their first year. And then finally, COVID-19 vaccine. This again is a recommended vaccine in the US for all children who are 6 months of age or older. And this has been evolving over time. And so I did not put the specific number of doses or the schedule on here, as this has changed multiple times over the last few years. The number of doses and the vaccine schedule will depend on the vaccine product that is administered. Here we have 2 products that are approved for children. Both products are mRNA vaccines. And depending on which brand the patient may get, that will also dictate how many doses and what the schedule looks like. Additionally, the number of doses and the schedule depends on whether the patient has received a COVID-19 vaccine in the past, the current age of the patient, and whether the patient is considered immunocompromised. And I can just say that we recommend these vaccines for all of our patients, especially those with comorbidities like chronic kidney disease, and those patients who are undergoing evaluation for kidney transplantation. Okay, so just checking the time. Moving on to the last objective, and that's really to just kind of understand some guiding principles for immunization of children with CKD and for children who may be immunocompromised due to immune suppression medications or due to the fact that they're undergoing kidney transplantation. And so the first one that I want to stress and that I have found very important, at least in our practice here, is that vaccination is a shared responsibility. We really recommend that specialists who care for children with underlying conditions or who may be immunocompromised share responsibility with the primary care provider for ensuring that appropriate vaccinations are administered to these patients. And so in our kidney transplant clinic, for example, one of my primary roles as the infectious disease provider for that team is to check the patient's immunization status and to recommend immunizations that they may be due for. And we have those immunizations that are available and can be given in our clinic. I think it's important to note this multidisciplinary approach. We have found that at least patients here who may have chronic kidney disease or some other underlying condition, they make frequent visits and have appointments with their subspecialists, sometimes even more than they may see their primary care physician. And so we find that if their nephrologist or their infectious disease doctor or their cardiologist, for example, educates the family and stresses the importance of needed immunizations, the patients tend to be more apt to get those vaccines, especially if those vaccines can be administered in the subspecialty clinic. And we have found that we have really increased our immunization rate among our patients with chronic kidney disease and who have undergone kidney transplantation by offering this in our subspecialty clinic. The second point is that the balance between risks and benefits of immunization can be complex or can be perceived as complex, especially to some of our patients and their families. In the healthy child, we review the great benefits of vaccination, which is the prevention of morbidity and mortality from vaccine preventable diseases. And we look at that benefit as really outweighing the minimal cost and possibility of side effects of vaccination. And so in this balance, we find that the healthy child in most cases will greatly benefit from the vaccine, and that is why we stress the importance of giving immunizations to our patients. In the patient with CKD or in an immunocompromised transplant patient, I would say that this balance tips even further to the benefits because we know that our CKD patients and our immunocompromised patients are at increased risk for developing infection and for developing more severe infection with vaccine preventable diseases. And I think that there are still minimal costs and side effects of vaccination, although we do probably think about this a little bit more and want to make sure we are doing and making the right choice for our patients. So I always think with the individual vaccine, will the vaccine work? We know that our kidney disease or our chronic kidney disease patients and our immunocompromised transplant patients may have a suboptimal response to vaccine. And so in that case, is it still beneficial to give the vaccine? And additionally, are there any special or unknown adverse effects that can happen in some of these patients? So for example, in a kidney transplant patient who is immunocompromised, obviously, in most cases, we would not give a live viral vaccine to that patient because we would worry that the attenuated virus could develop, or that patient could develop true infection, and we don't want that to happen. And so we, in those cases, with live viral vaccines, we do not tend to administer those vaccines to those patients. And so the balance of the risks and benefits may depend greatly on the prevalence of the disease, the chance the patient will be exposed to that disease, the degree of the kidney dysfunction or immune compromise, the type of the vaccine, and how well the vaccine will work in that person. And so this has been illustrated by many studies, but one in particular that I just wanted to mention was a study of 50,000 adult renal transplant recipients who did get the influenza vaccine. It did not show any significant deleterious effect from the vaccination in those patients. And importantly, the vaccination during the first year after transplantation was associated with decreased risk of allograft loss, ICU admission, and death. And so in that case, the flu vaccine was extremely important and helpful in this particular population. I mentioned again that the immune responses may be suboptimal in our different populations, but in most cases, that shouldn't be a reason to withhold a vaccine, because some protection is likely better than no protection in those cases. And as long as the vaccine is not going to do harm, we do recommend that the immunization be given. We also know that immunization earlier in the course of illness is likely going to have better seroprotection and better antibody response. And so we look at this as a window of opportunity to give children their immunizations on time before they developed end organ or end stage renal disease and before they undergo immunosuppression for transplantation. And then finally, it is recommended to immunize close contacts of children with chronic medical conditions or immunocompromise. And so we stress the importance of creating a circle of protection. And I stress to you all to continue to advocate that healthcare workers, household members, teachers, coworkers, classmates, grandparents, the community at large, continue to get their immunizations and vaccines in order to create herd immunity and circles of protection around our patients who may not respond as well to immunization. And so all recommended inactivated vaccines should be given to close contacts, and all routinely recommended live attenuated vaccines can also be given to close contacts. It's very rare that transmission of vaccine virus from live attenuated vaccines occurs. But even if it does, it is thought to result in milder disease than that from wild type virus. And therefore, it is recommended, at least in the United States, to immunize close contacts with all of the routinely recommended immunizations. The only two we do not give here in the US, and we do not recommend that close contacts get the oral polio vaccine or the smallpox vaccine, because the risk of transmitting those viruses is much higher than the risk from the other vaccines that I have listed here. And so in summary, it's important that we take a multidisciplinary approach to immunization. We should be immunizing early in end-stage organ disease and prior to transplant. I stress to you to immunize everybody, understand and know the specific recommendations for patients with CKD or who are on hemodialysis. And if you are able to in your clinics and in your hospitals, develop a system and be sure to continue to educate and address vaccine hesitancy, which unfortunately we are seeing a significant increase in here in the United States. And so I thank you for letting me speak today, and I hope this hit some highlights for you all, and I'll take any questions now.
Thank you, Dr. Victoria, for your interesting lecture. It's time for question and answer. If any Vietnamese colleague have a question for Dr. Victoria, you can speak directly in your microphone, or you can type on the chat box, and Dr. Duyên will help to translate.
It's very interesting, the presentation. So I have mentioned about is there any condition from that we can postpone not tradition for giving viruses vaccine for children with CKD.
I'm just going to kind of clarify and just correct me. You asked if there was any reason we could postpone a specific vaccine, or
In general, not only for Arcturus Lee vaccine.
I may not be hearing you correctly. Sorry. Let me turn up everything. So we, in general, we try not to postpone immunizations, but we will in kidney transplant, if that's, I don't know if that's what you're specifically asking or not. So if a patient undergoes transplant, we will wait to, start giving vaccines again for at least 6 months after the transplant. And so we will not start giving more vaccines until they are at least 6 months out from transplant. But if I misunderstood your question, I apologize.
So because in Vietnam, we have the guideline actually for the regulation for screening the Welsh baby before it receives the vaccine, so that for on child with acute disease or progressive disease, we should postpone.
Postpone in those cases. Yes,
Yeah,
I
yeah.
agree. I agree.
Yeah.
Sorry, I didn't understand you at first. Okay.
Okay, good. So if we connect question for Dr. Wang, how you define the patient with CKD is not progressive, because if you don't define that, it's very hard to give vaccination in the patient with CKD.
So you're saying that it depends on the definition of what stage of CKD the patient has?
Yeah.
Yes, and I didn't, so our guidelines don't necessarily give specific recommendations one way or the other based on CKD staging. It's just recommended that if you have kind of any stage of CKD, the pneumococcal vaccine, for example, should be, prioritized. And then for patients who are on dialysis, that alters how we may approach hepatitis B vaccine. And all the other vaccines are recommended per the usual schedule. I do see a question in the question and answer. I see 2 questions. A patient on hemodialysis, should he get a vaccination before or after the time of hemodialysis? So usually if they're actually at the unit if you're talking about actually getting dialysis at this moment in time, I usually give it after the dialysis session if we need to give it. I think that's what that question is referring to. And then should we increase the dose of vaccine because it was removed partially after dialysis? And so that's why if I'm going to give a vaccine at the time of dialysis, I usually wait and do it after that specific session, so we don't worry about any sort of removal during that particular session of dialysis. Does that make sense?
Hello. Hello, my name. Yeah, my name is from Children Hospital 2. Can I comment one idea and make a question for you?
Yeah,
Yeah.
Dr. Wing, you can ask directly Dr. Victoria, please.
Yeah, they recommended that we should double the dose of HPV vaccine for the patient with pre-transplantation and the patient with hemodialysis. I don't see you mentioned in your presentation. In our experience in our center, we usually double the dose of HPV vaccine as the recommendation. At the beginning, we have some difficulty from the doctor. They don't agree that we shouldn't increase the dose of vaccine. But after that, for a long time, we check the titers of antibody. We saw that the patient, if we remain use the same vaccine with other children, the titers of antibody is low. So after that, we increase the dose of vaccine as recommendation.
And which vaccine is that you're talking about?
SBB. Hepatitis.
Hepatitis B. Okay. Yes.
Yeah.
Yes.
Happy.
Yeah.
Yes. So we don't have a specific recommendation to increase the dose in children. Some centers here in the United States will do that for children who are on dialysis. And it is a recommendation for adult patients in the United States that if they do not respond to the first series, or if they have a low titer and they're on dialysis, then we do increase the dose and give a higher dose hepatitis B vaccine. That is not routine in children in the United States, but it is done at some centers. They do it kind of off guideline, which is probably okay, but we have not done it routinely at our center.
Yeah, now it's recommended in KDIGO guidelines. Yeah. Thank you. And how about the tuberculosis vaccine? Do you have any recommendation? Yeah.
Yeah, so we do not do BCG. Do you do BCG? Yeah, that goes. We do not do that in the United States. We do not recommend it if you are immune compromised, like if you're already undergoing immune suppression or kidney transplant. I would not recommend it. I did not specifically look at the recommendation in chronic kidney disease patients specifically, because we don't have that vaccine here in the United States.
Yeah.
Can you tell me what you all do? Do you give it in your patients?
No.
Okay.
Yeah, it's the same as other patient. We do the BCG vaccines at neonate. Yeah, at birth. Yeah. Thank you.
So, return to Dr. Wing question. I have another question related to HPV vaccine for children who prepare for transplants. So in your guideline, you say for non-responder with HPV vaccine, in such cases, can we double the dose of HPV?
Yeah, so we do not routinely increase the dose of the hepatitis B vaccine here in the US in children. We do not routinely increase the dose, but in adults, they will.
So if a patient who do not respond with HPV vaccination, so we can transplant for this patient?
The transplant, we do transplant them even if they do not respond to the hepatitis B vaccine. Is that the question? Sorry, I may have.
Yes. I want to ask, so if the patient do not respond with HPV vaccination, and we can choose that patient for transplantation, renal transplantation or not?
We do. We will still transplant them even if they do not respond to the vaccine.
Yeah.
We just understand that they are at increased risk for hepatitis B infection because they do not have measurable protection. And if they were to be exposed to hepatitis B virus, then we would give them immune globulin to try to prevent transmission. Does that, like we give passive antibody, immune globulin?
Yes, thank you.
I have a question. We don't have PPSV 23 in Vietnam, but in your lecture you said that even though the patient had 4 series of BCP13, you still vaccinate the PPSV 23. Is that right?
That is correct. We give the pneumococcal conjugate vaccine series, and then if they have a high-risk condition like CKD or transplant, then we also give the Pneumovax, just as added protection against those extra serotypes that were not included in the conjugate vaccine. Does that make sense?
Yes.
Yeah, so it's the guideline. It's the guideline from CDC. You should
Correct.
follow it. Yeah.
Yeah, so the Pneumovax, we do not give to healthy children, only the high-risk children.
Dạ đúng rồi. Mình chỉ có 10, 13.
Yes, we have. We have BPSV. So it's just for patient with a high risk, because the BCV is not enough, so that we can use one model of BCV 23 to increase the immunity for at least additional serotypes of BCV with Streptococcus pneumonia.
So I can tell you, oh, go on.
Do we have a PPSV 23 in our hospital, Dr. Yang? In
Not
children's
yet, but the other we have.
hospital?
If you need, you can bring that to our hospital. But you have to promise to view it.
I work in some vaccination center in clinic 315 and Kepler's clinic. They don't have that vaccination, and I can see that Pasteur doesn't have that vaccination. So where can we find the PPSV 23 in Vietnam?
Should find just contact to the BNBC. Maybe they have. Our Pasteur Institute. Yes.
Thank you for your information, Dr. Yang.
So what PCV number do you have? What conjugate vaccine do you have? What number?
13.
13. Okay. So we just got 15 here in the United States, and then 20 is coming. We don't have it yet, but my understanding from the CDC is that perhaps once we have 20, we may not be giving the PPSV 23 anymore, because the 20 will protect against most of the common serotypes. But that is not official.
That is the policies of the company, so that they limit to sell the PPSV 23 for the Vietnam.
Không biết là các đồng nghiệp có câu hỏi gì thêm cho bác sĩ Victoria không ạ? Nếu có thì xin đồng nghiệp đặt câu hỏi luôn để cho bác sĩ Victoria trả lời, tại vì bên đó cũng là tương đối là trễ giờ rồi. Thành ra là nếu có câu hỏi thêm thì xin đặt câu hỏi lại. Anh Nhàn có hỏi
question. Yeah, one more question. Victoria, do you have any screening questionnaire recipes for the CKD patient with the CKD?
We do not have any specific questionnaire or screening questionnaire for these patients that I'm aware of.
Okay, thank you.
so it's a bit late in USA, and now we don't have any more question about your topic. So maybe we will stop the webinars now. Finally, I would like to say again my special thanks to Dr. Victoria and Dr. Ding, who help us to have interesting lecture about immunization on CKD patient. Thank you again, and hope we can have more chance to learn with you again.
Thank you,
Bye,
Victoria.
Dr. Ding. Bye,
That's
Dr.
excellent
Victoria.
talk. Yeah.
Thank you. Goodbye, Victoria.
Thank you. Bye.
Thank you. Goodbye.